is a lot of controversy over the phenomenon of transgender people. In a society where LGBT identification is becoming more common, especially in Generation Z, the question of how we ought to treat transgenders as well as gender nonconforming people in general is salient. Here, I want to focus on the way that gender dysphoria is treated by the medical establishment. We're told that transition is the only treatment for gender dysphoria, and so people are set on the path of gender affirmation alarmingly quickly. There are basically no safeguards, no trial period, nothing exists to make sure that someone should really transition. We're also told that gender affirmation is safe, that it betters the lives of transgender people, but is that true? Let's find out. One of the more common treatments for gender dysphoria is cross-sex hormone therapy or hormone replacement therapy. Again, we're often told that it is safe, that it is without risks, or that the risks are minimal. I will show that HRT is, in fact, quite risky. Something that is tragically under-discussed in the conversation over gender-affirmative care and cross-sex hormone therapy is the risk of autoimmune disorders and even tumors or strokes that result from using these drugs. It's well known in the literature that autoimmune diseases are more frequent in women because estrogen activates immune responses. Women, therefore, have stronger immune responses than men. In a population, such as trans-identifying men, who are taking exogenous estrogen, we can expect an increased likelihood in risk markers for autoimmune diseases. This is precisely what was found in Ramos et al. 2019. Of the total of the specific autoantibodies studied, we found ANA positivity in 20/87 TGW, 23%, and in 19/59, 32% TGM. Comparing with the positivity of specific antibodies obtained in our controls as an average not exceeding 5%, these values found in the transgender population were statistically highly significant in both groups. Additionally, there is at least one case of an individual taking exogenous estrogen who developed the rare autoimmune disorder lupus, according to Santos Ocampo, 2007. And, funnily enough, high doses of exogenous estrogen might turn you into a vampire. Well, sort of. It can cause porphyria, a skin disease that can cause liver damage and itching upon exposure to sunlight. In transgender women, hormone therapy involves higher estrogen doses than those used for other indications, raising concerns of risk for conditions associated with estrogen exposure, including PCT. Researchers at University of Pittsburgh Medical Center and a colleague at Johns Hopkins University in Baltimore reported the case of a 55-year-old transgender woman who developed PCT following a change in hormone therapy that led to estrogen levels above the therapeutic range, supratherapeutic. The woman was admitted to the hospital with a 3-month history of burning pain, itching, and recurrent blisters on her hands and forearms after exposure to sunlight. She reported no personal or family history of liver disease, iron abnormalities, or blistering eruptions. She was a smoker and reported drinking 2 beers a day. While the woman had been taking oral estradiol, the most active form of estrogen, daily for the past 23 years, her hormone therapy changed 1 month before symptom onset. In an attempt to better control gender dysphoria, she began a trial of progesterone, 100 milligrams a day, the other main female hormone, and increased her daily estradiol dose from 2 milligrams to 4 milligrams. This was found in the study Collison 2020. In addition to the risk of autoimmune disease, exogenous estrogen can also increase the risk of strokes, blood clots, and heart attacks. The study found that transgender women who were assigned the male sex at birth were twice as likely as cisgender men or women to have the blood clot condition venous thromboembolism. Transgender women on hormone therapy were also found to be 80 to 90% more likely to have stroke or a heart attack than cisgender women. Another serious risk is that of benign tumors, according to certain case studies found in the Systematic Review, McFarland 2018. The use of antiandrogens was associated with several cases of brain tumors. Exogenous estrogen also predictably increases the risk of breast cancer, including in trans-identifying men. According to de Block et al., the study showed an increased risk of breast cancer in transgender women compared with cisgender men, and a lower risk in transgender men compared with cisgender women. In transgender women, the risk of breast cancer increased during a relatively short duration of hormone treatment, and the characteristics of the breast cancer resembled a more female pattern. HRT is not the only risky component of gender-affirmative care. Sexual reassignment surgery is very risky as well, and it does not seem to improve quality of life for transgender people. Supporters of gender-affirming care will often claim that the alternative is to undergo transition and sexual reassignment surgery / gender-affirmative procedures, or death. This, however, is a false dichotomy. It not only obscures the fact that SRS and gender affirmation lead to increased risk of mortality by suicide and surgical complications, but also totally precludes exploration of the possibility that a non-affirmative approach to care, such as treating underlying mental disorders that might lead to gender dysphoria, such as autism or schizophrenia, might lead to increased outcomes instead. And yes, transgender people are much higher in various mental disorders than the general population, which may in fact be one of the causes of gender dysphoria. According to Warrior et al. 2020, transgender people are more likely to be autistic or schizophrenic, and there are many other comorbidities as well. We might briefly recall the fact that Ted Kaczynski, who was diagnosed with schizophrenia, also had gender dysphoria. The YouTuber Vaush has been a particularly loud voice in the advocacy for gender-affirmative care. To this end, he created a document response to critics of transgenderism. Vaush claims that this includes a quote-unquote meta-analysis that definitively proves that sexual reassignment surgery and gender affirmation is an effective treatment for gender dysphoria. First of all, Vaush thinks this is a meta-analysis, but it's not. Quote, "A meta-analysis is the use of statistical methods to summarize the results of studies. No attempt to collate the quantitative results of the studies and to perform statistical analysis was made here. Therefore, the Cornell review that he presents is not a meta-analysis. Instead, it is a systematic review. A systematic review is a document in which studies, admitted according to some kind of inclusion criteria, are evaluated according to whether they positively or negatively treat something. There are also several problems with the studies included in the systematic review. Here are a few points to keep in mind. Many studies of SRS outcomes are not longitudinal. They typically only reach out to about a year post-op, and this is a problem because improvements typically decline after the first year, which we can see in Lindqvist 2017, which was a study of 190 patients pre-op and up to 5 years post-op. It's one of the few longitudinal studies of SRS. This decline after the first year of treatment is called the first-year honeymoon phenomenon. Additionally, there is a huge problem in studying the transgender population, since the majority of those who take part in studies tend to drop out. The probable reason they drop out is that they have had a very negative experience. This means that studies on the transgender population may appear to be generally positive, when in reality, the chance to even look at negative results has been completely precluded. First of all, many of the studies included in this systematic review, which were indicated under positive, are of very poor quality. Many of them were simply interviews, which do not have much value due to the lack of hard data, as well as the highly individualized and therefore biased nature of the responses. Needless to say, an interview lacks any controls, any measures, and has a sample size of, well, 1. These are therefore not sufficient for us to make an evidence-based assessment of the outcomes of sexual reassignment surgery. Interviews may be helpful in ascertaining some of the sociological impacts of transgenderism and the way society treats it, but it tells us nothing about whether a surgery is a proper treatment for gender dysphoria. Lastly, the majority of studies on the transgender population lack controls, which makes the value of the data quite problematic, since we have nothing to compare the results to. Now, furthering the honeymoon first year hypothesis, Jinne et al. 2011 shows increased morbidity beyond the 10 years post-transition mark. From a report drafted when Medicare was considering covering SRS on its policies, the most comprehensive study with functional endpoints, the Swedish study that followed all patients who had undergone reassignment surgery at mean age 35.1 years over a 30-year interval and compared them to 6,480 matched controls, identified increased mortality and increased psychiatric hospitalization. The mortality was primarily due to completed suicides, 19.1-fold greater than in control Swedes, but death due to neoplasm and cardiovascular disease was increased to 2.5 times as well. the divergence in mortality from the Swedish population did not become apparent until after 10 years. The risk for psychiatric hospitalization was 2.8 times greater than in controls, even after adjustment for prior psychiatric disease, 18%. The risk for attempted suicide was greater in male to female patients regardless of the gender of the control. Unfortunately, the study was not constructed to assess the impact of gender reassignment per se. The finding of the study, again, demonstrated that reassignment surgery does not return patients to a normal level of morbidity risk, and that the morbidity risk is significant because of its clinical importance, its persistence over the interval of data collection, and the increase in risk over time for the individual. Additionally, the highest quality studies on sexual reassignment surgery show the worst results. The results were inconsistent but negative in the best studies, i.e., those that reduce confounding by testing patients prior to and after surgery, which use psychometric tests with some established validation in other populations. Atkins et al. 2004, Balsham et al. 2011, Chan Altman 2005, Deeks et al. 2003, Guyette et al. 2008, Koons Oxman 1998, Koons et al. 2007 and 2011, Odgaard Jensen et al. 2011. This is also from cms.gov. One might claim that some studies that show no negative outcomes for SRS are evidence that SRS can be an effective treatment, or at least that there is no reason to refuse SRS. However, many of these positive studies seem to ignore the obvious fact that surgical procedures have high rates of complications. A study showing no negative outcomes for SRS does not support the use of SRS in the treatment of gender dysphoria. If a study shows no psychological improvement years after SRS, and if we know that surgical procedures often carry a huge risk of harm, then we can conclude that it would be a negative outcome, generally speaking, due to the ongoing need for medical intervention that seems to characterize around 79% of SRS cases. Even positive studies like Ainsworth 2010 show that post-SRS patients rate higher than the general population for physical limitations and lower for general health. And in Cristofari 2018, it becomes evident that SRS has an extremely high rate of complication. We need to be cautious when we look at any study with inconclusive psychological results. Outcome measures can be confounded by the increased level of psychological therapy and support provided long-term to post-SRS individuals. Most, if not all, studies fail to control for this, and some acknowledge this as a weakness. So essentially, it's not possible to tell to what degree therapy alone accounts for positive outcomes rather than SRS itself, like quality of life or psychological health. Now, let's take a look at a study that was, oddly enough, considered positive in the systematic review, namely De Silva et al. 2016. The participants showed significant improvement after SRS in domains 2, psychological, and 4, social relationships, of the WHO QOL 100. In contrast, domains 1, physical health, and 3, level of independence, were significantly worse after SRS. Individuals who underwent additional surgery had a decrease in quality of life reflected in domains 2 and 4. During statistical analysis, all results were controlled for variations in demographic characteristics without significant results. This study actually shows many negative outcomes. It is noted as having a moderate risk of bias in Nobili 2018. In the abstract, we are given aggregate domains of well-being, but when facets within the domains are analyzed individually, it becomes evident that SRS negatively impacts energy, fatigue, sleep, negative feelings, and others, even though it improves sexual activity, freedom, physical safety and security, financial resources, and health and social care. Some who underwent SRS underwent additional procedures. These interventions were intended to repair functional or aesthetic concerns and to resolve complications of the original procedure. Among the most frequent new interventions were urethroplasty, 9 patients, 19.14%, and vaginoplasty, 6 patients, 12.76%. For the surgical procedures, only 16, 30.04%, did not undergo new interventions 1 year after SRS. Although, and I'm adding this in, 65% in general had intervention. Individuals who underwent surgical procedures during the 1-year follow-up period after SRS showed worsening in domains 2, psychological, and 4, social relationships. There are several limitations of this study, including the evaluation period, which was 1 year after SRS, the post-operative recovery times of the patients, and different levels of quality of life among individuals. Therefore, we emphasize the need for additional follow-up trials to assess satisfaction with SRS. As we can see, satisfaction is worse when an SRS patient requires additional surgeries, and they frequently require revisions. This isn't a problem unique to Brazil. SRS is very prone to complications, requiring surgical revision up to 79% of the time. Secondary revision surgery after SRS has been frequently reported, whichever the type of primary SRS technique, up to 79% for van der Sluis et al. Nevertheless, authors have observed that MTF transgenders' quality of life after SRS is inversely proportional to the amount of additional revision procedures. It is quite peculiar that the vast majority of transgender individuals are biological males. Trans activists will claim that there is some genetic or spiritual origin for transsexuals, that men and women are born in the wrong bodies, or that there is a brain-body mismatch. Is this true? How does it comport with the aforementioned sexual asymmetry? Why do people become trans? Ray Blanchard, an influential sexologist, has a potential answer as to one cause of transgenderism: autogynephilia. Autogynephilia is a sexual fetish in which a man is aroused by the thought of being or resembling a woman. In a 1989 study, Blanchard gauged the degree of autogynephilic fantasy in both homosexual and non-homosexual trans-identifying men, and he discovered that non-homosexual trans-identifying men were much more likely to be autogynephilic. This may explain why the vast majority of transgender individuals are men rather than women. Helen Joyce, in her book Trans: When Ideology Meets Reality, elaborated on this hypothesis. She concluded that gender dysphoria is nothing more than a distressing sexual fetish, constituted by arousal at the thought of being the opposite sex. Several accounts of gender dysphoria include male writers imagining being the female during sex or during orgasm. We might also think of the obsession with sex and sexiness that transgender people have. They reduce femininity down to a fetish. Other trans-identifying men remark that they feel sexual arousal when thinking of being a woman or doing routine feminine activities, which actual women certainly do not experience. We might also think of the more recent phenomenon of trans-identifying men claiming to have periods or even to have symptoms of pregnancy, which is obviously impossible. Thus, sexual dysphoria has a unique character that sets it apart from a genuine gender-based mistake of nature, as they claim. What is salient about people with gender dysphoria is the need for constant validation. For this reason, some detransitioner bloggers have hypothesized that narcissism plays a significant role in gender dysphoria, which they have derived from some degree of self-introspection. Narcissists wish to have a perfect body, which is part of their grandiosity. They wish to have attention paid to them, and they are fundamentally also insecure, as well as being without a stable sense of self. We can see elements of all of this in the presentation of many transgender people. They are hyper-fixated on their appearance, which is not normal. They pay tons of money to have cosmetic surgical procedures done, and they try as hard as possible to appear sexy, to appear attractive. This continual search for validation plays into the narcissist's need for attention and approval, and it alleviates the narcissist's insecurities. Lastly, the lack of a stable sense of self may contribute to the general lack of a sense of one's own personality and gender, leading to a sort of emptiness or dysphoria. It's worth noting that, as I've already explained, gender dysphoria is comorbid with many mental disorders, so the involvement of narcissism cannot be discounted. As for the brain-body mismatch hypothesis, there is actually some evidence for this. Gender atypical behavior is correlated with people having brain morphology that more closely resembles that of the opposite sex. However, it's important to note that this is also true in homosexuals, not just transgender people, and that the brain morphology is still more close to one's own natal sex than to that of the opposite sex. To claim that this is evidence that people are born trans or born in the wrong bodies, we would have to disentangle gender dysphoria from internalized homophobia, and also we would have to ignore that, for example, male-patterned brains remain to a large extent male-patterned. Informal proof against this brain-body mismatch hypothesis exists. We are all familiar with the stereotype that trans-identifying men are all programmers, that they all love retro video games or that they're all intensely into obscure political philosophies like communism or fascism. It appears that despite the claims of trans-identifying men that they have an essentially feminine mind, they exhibit profoundly masculine patterns of interests, as well as a very male pattern of sexual behavior. And to this end, we might also note the prevalence of autism, which is essentially extreme maleness in the brain among the transgender population. As for the matter of trans-identifying women, there's reason to suppose that this is largely a social contagion. Littman 2018 offers compelling evidence of this phenomenon, which primarily affects girls. This is summarized by Psychology Today. In a recent survey of 250 families whose children developed symptoms of gender dysphoria during or right after puberty, Lisa Littman, a physician and professor of behavioral science at Brown University, found that over 80% of the youth in her sample were female at birth. Littman's study reported many other surprising findings. To meet the diagnostic criteria for gender dysphoria, a child typically needs to have shown observable characteristics of the condition prior to puberty, such as a strong rejection of typically feminine or masculine toys, or a strong resistance to wearing typically feminine or masculine clothes. Again, 80% of the parents in the study reported observing none of these early signs in their children. The plot thickens again. First, many of the youth in the survey had been directly exposed to one or more peers who had recently come out as trans. Next, 63.5% of the parents reported that in the time just before announcing they were trans, their child had exhibited a marked increase in internet and social media consumption. Following popular YouTubers who discussed their transition thus emerged as a common factor in many of the cases. After the youth came out, an increase in distress, conflict with parents, and voiced antagonism toward heterosexual people and non-transgendered people, known as cis or cisgender, was also frequently reported. This animosity was also described as extending to males, white people, gay and lesbian non-transgender people. The view adopted by trans youth, as summed up by one parent, seemed to be that, in general, cisgendered people are considered evil and unsupportive regardless of their actual views on the topic. To be heterosexual, comfortable with the gender you are assigned at birth, and non-minority places you in the most evil of categories with this group of friends. Statements of opinions by the evil cisgender population are considered phobic and discriminatory and are generally discounted as unenlightened. Parents further reported being derogatorily called breeders by their children, or being routinely harassed by children who played pronoun police. The observation that they are no longer recognized by their child's voice came up time and time again in parental reports. In turn, the eerie similarity between the youth's discourse and transpositive online content was repeatedly emphasized. Youth were described as sounding scripted, reading from a script, wooden, like a form letter, verbatim, word for word, or practically copy and paste. Littman raises cautions about encouraging young people's desire to transition in all instances. From the cases reviewed in her study, she concluded what she terms rapid onset gender dysphoria, ROGD, appears to be a novel condition that emerges from cohort and contagion effects and novel social pressures. From this perspective, ROGD likely exhibits an etiology and epidemiology that is distinct from the classical cases of gender dysphoria documented in the DSM. Littman hypothesizes that ROGD can be cast as a maladaptive coping mechanism for other underlying mental health disorders such as trauma or social maladjustment, but also for other exceptional traits like high IQ and giftedness. The peer support, prestige, and identity leveraged by the youth who proudly come out as trans certainly appears to be protective in their circles. As Littman's study shows, this social signaling strategy also comes with strong disadvantages, particularly as it increases conflict between trans youth and the cis majority of the population, which tellingly includes a majority of the LGBT community. As I've mentioned, until recently, there hasn't been much academic attention, or otherwise, paid to the existence of detransitioners. However, what has been known for a long time is that the vast majority of children with gender dysphoria will desist by 18. According to Singh et al. 2021, 85% of boys, which is a figure much higher than previous studies, studied would become desisters, while only 15% remain persisters. Also of note in this study is the finding that a majority of boys studied, 63.6%, indicated homosexual or bisexual fantasies, potentially validating the hypothesis that a significant amount of those diagnosed with gender dysphoria are simply homosexuals attempting to wrestle with the inherent confusion that one might experience in the face of same-sex attraction, and there is also the possibility of this being caused by internalized homophobia. In other words, they are not really trans, but they are gender atypical youths who are in the process of figuring out their sexuality. It is precisely this population of biphilic or androphilic boys that exhibited greater deviation from gender norms than their peers. That homosexuals have gender atypical traits is well validated in the literature, both in Zuger 1978 and Zuger 1984. This will be important later when we discuss the difficulties of growing up gay in the postmodern world. Things have truly changed. One serious problem with the medical approach to transgenderism and with gender affirmation in general is that people are simply not sufficiently informed about the risks of procedures. According to an online survey of members of detransitioner communities, 45% felt that they were not properly informed about the health implications of treatments. A further 33% felt that they were only partly informed. Needless to say, an important part of medical ethics is informed consent. And if that consent is not informed, it cannot be consent. So why do people detransition? Trans critics will claim that people are pushed into detransitioning by society or by discrimination, but this proves to be untrue. The least common reason people detransition is discrimination. And more alarmingly, half of respondents felt that transition was not helping their dysphoria. The most common reported reason for detransitioning was realizing that my gender dysphoria was related to other issues, 70%. The second one was health concerns, 62%, followed by transition did not help my dysphoria, 50%, found alternatives to deal with my dysphoria, 45%, unhappy with the social changes, 44%, and change in political views, 43%. At the very bottom of the list are lack of support from social surroundings, 13%, financial concerns, 12%, and discrimination, 10%. Vanden Bush, 2021. Saliently, a big reason why people transition is internalized homophobia. To put it simply, the trans community is not very kind to homosexuals, and very often, it pushes people who would otherwise just be gay into transitioning by pathologizing their gender atypical behaviors. Vanden Bush also points out that a motivator for detransition is also a feeling of regret. Trans activists will often tell the lie that almost no one regrets transition. This is simply false, and they will pressure people to not come out about detransitioning. Similarly, the current study suggested that detransitioners have important psychological needs. This was made visible on the one hand through the fact that a majority of respondents, 65%, reported the need for help in working on comorbid mental conditions related to gender dysphoria and in finding alternatives to medical transition. Other needs were reported by a majority of participants, such as learning to cope with feelings of regret, 60%, learning to cope with the new physical and/or social changes related to detransitioning, 53%, and learning to cope with internalized homophobia, 52%. The LGBT community, as well as various care providers, is also overtly hostile to people who decide to detransition. If it were really about the well-being of trans individuals, shouldn't these groups support the decision to detransition? Only 13% of the participants reported having support from an LGBT+ or trans-specific organization while detransitioning, compared to 51% while transitioning. In addition to that, many respondents described experiences of outright rejection from LGBT+ spaces due to their decision to detransition. Studies on detransition are still in their incipients, much like studies on the trans community itself. It is small and hard to study, and many people simply don't show up to be studied. Sample sizes will be small and convenient, never up to the standards of statistical rigor. But what we have seen so far is quite worrying. The trans community is causing people a lot of damage and then forcing them away when they ask for help. Is this really for the benefit of humanity? Is it good for society? Is it good for trans individuals? I don't think so. One feature of transgender ideology that is often discussed by trans-exclusionary radical feminists is the fact that gender itself is dissolving. What it means to be a man, or especially to be a woman, is becoming labile, flexible, arbitrary. The result is the social erasure of femininity and of masculinity, and the rise of what we might call queerness. There exist people who want to push this through, to abolish gender, under the belief that sexual norms are fundamentally enforced by violence. This is the tired refrain of postmodern ethics, that nothing exists as a consequence of nature or inheritance or even divinity, but rather, everything is reducible to language categories and power relationships. Even if this small cadre of people does nothing, the trans ideology itself has put the concept of gender into peril. Trans ideology formally denies that gender has a hereditary component. However, this is in reality untrue. The great Norwegian documentary, Brainwash, noted that there is evidence that even primates have gendered toy preferences. Since primates are not socialized according to gender norms, this indicates that gender preferences, and even gender performance, is heritable and has a biological basis. The way that modern gender academics separate out sex and gender performance has in reality no foundation. The way that modern gender academics absolutely separate out sex and gender has no reality, even though there may be some variance. Sex and gender are fundamentally interrelated. The same toy preferences are also expressed in human babies before they even have a chance to be socialized. More proof exists contrary to the hypothesis of gender constructionism, such as the John Money gender experiment, also covered in Brainwash. David Raymer was born a boy. However, a botched circumcision left him with ambiguous genitalia. John Money decided it would be an excellent opportunity to test whether gender was socially constructed and conditioned. To this end, he instructed the parents of the boy to raise him as a girl. But when puberty struck, and therefore when androgenic testosterone began to flood his body, he realized spontaneously, despite the conditioning, that he was a male. This experiment had a tragic ending, as at the age of 38, David Raymer committed suicide due to the psychological difficulties the experiment had caused him in his formative years, which lasted into his adulthood. This experiment obviously raises various ethical concerns, but it proves the damage that the social constructionist view can have on account of its absolute falsity. The erasure of femininity and masculinity is itself seriously problematic. To be normal, to be a straight male or to be a straight female becomes pathological. A rather funny example of this fact was the super straight trolling campaign, in which members of Twitter created a straight identity movement and even designed a sexuality flag for it. They were mocked, reviled, and insulted by progressives for their audacity, which was simply to attempt to integrate themselves into the movement of sexual progressivism itself as a distinct identity. We can see how the program of the sexual revolution has not been just the liberation of sexual minorities, but it has also been the absolute positive destruction and problematization of normality itself. Needless to say, the healthy relationship between men and women is fundamental to the ordering and functioning of society. The vast majority of people are heterosexual and cisgendered, therefore, to ensure that they have a secure place in our society is paramount. The phenomenon of gender accelerationism effectively erases them by leg sweeping out gender. Most people will no longer have a proper sense of identity, any kind of validation, or self-esteem. What privileges transgender people assign for themselves are forbidden for everyone else. In a lot of ways, the trans movement has completely overstepped its aims. If the goal of the trans movement were to gain acceptance by the mainstream population, then obviously, gender accelerationism is antithetical to that purpose. If one wishes to win trans allies, what sense is there in insulting and in pathologizing them by calling them cishet or calling them cisgendered? It simply does not make sense. The trans movement will find out that, as long as it continues to erase sex and gender, to deny the fundamental biological reality of the matter, and to obscure the biological relationship between sex and gender, it will turn the majority against them. This is not good for them in the long run, and it's not good for society. Finally, I want to point out that gender accelerationism has absolutely destroyed the nerd subculture. If you're a nerd, but you're not trans, you're severely out of place these days. As Littman noted in the aforementioned phenomenon of rapid onset gender dysphoria, One of the risk factors for social contagion is giftedness and high IQ, as we might find in the nerd population. Many smart people and smart nerds are figuratively fed into the trans meat grinder. They show up wanting to talk about Warhammer or some kind of autistic narrow interest, and they end up getting a bottle of pills instead. Even simply being gay has come under fire, especially if you are white and comfortable with your identity. One of the fundamental reasons that transgender individuals are motivated to detransition is the realization that they will never be a biological woman. No amount of surgical intervention nor exogenous hormones can ever change one's biological sex. It is not possible to change one's chromosomes. It is not possible for a man to become a fertile woman. And what's more, these surgical procedures fundamentally sterilize a person. They render one incapable of having normal sexual intercourse, and most importantly, it makes it impossible to have children. Many detransitioners regret the most that they will never be able to have a family. The harsh reality of the detransitioner experience calls into question the entire presumption of the trans ideology. Are we really being honest about reality when we claim that men can menstruate, that they have periods? Is it fair to transgender individuals to promise them that they can reach an unobtainable goal, to become the opposite sex? If we are to be realistic, and to avoid self-deception, we would have to admit that the only possibility a transgender person has is to become a transgender person. The bar is lowered to passing and attaining validation, but the fundamental mismatch that is claimed can never be resolved. The issue of dysphoria, therefore, never goes away. This is a strong reason to suppose that absolutely no one should ever transition. As one trans YouTuber said, when archaeologists dig up a transgender person's bones in 1,000 years, they will say definitively that this is a male or that this is a female. To believe that anything else is true is simply self-deception. As long as we tell lies, as long as we deceive innocent people, we are doing them harm, and the medical establishment does this daily. There are cases in which medical professors have even been censured or fired for not using a person's preferred pronouns, even when ascertaining one's biological sex is a medical necessity. This is part of the reason why conservatives revile the trans community. It is fundamentally telling lies about biological and social reality. And what's worse is that it is actually harming people through pushing them into transition. Transition increases dysphoria because it can never cure dysphoria. The more we subject vulnerable people to this ideology, the more we'll be pushed towards suicide. The alternative is not death or transition, it is life or transition.